Welcome to Department of Medicine Grand Rounds. I'm Bob Wachter, chair of the department. Today we have a special return visitor who is Mike Incze, who is associate professor of medicine at the University of Utah. I say return because Mike was a resident here at our San Francisco General primary care program, which he attributes much of his career to things that he learned there, and look forward to hearing more about that. He's unfortunately left the fold, but has done extraordinarily well. I was just talking to several colleagues who've continued to work with him, and he's really become a national leader in his area of interest. His area is in some ways the combination of primary care and addiction medicine. As I said, he's associate professor in the Division of General Internal Medicine at Utah. His research interests is on models to improve the care of patients with substance use disorders, and particularly with a focus on transitions of care, and maybe particularly within that, transitions from the hospital to outside of the hospital. He's worked on a number of different collaborative care models, and both building the models and also studying them to try to understand what works. And as I say, he's had a major impact, and we're very lucky that he continues to collaborate with many of our colleagues here, and we're thrilled that he is coming back to visit us. So Mike, welcome.
Thank you so much, Dr. Wachter, and yeah, it is truly a pleasure to be back here. My name is Mike Incze. I'm associate professor in the Division of General Internal Medicine at the University of Utah, where I practiced primary care and addiction medicine, and finished internal medicine residency here in 2019. And it is, yeah, truly inspiring to be back. So many great memories from this institution, and truly any success that I've had in my career to date, and who I am as a clinician is largely due to the mentorship and camaraderie that I experienced here. And I really do believe that, UCSF is a place that instills in young physicians and other young healthcare professionals that, you can and should change the way that medicine is practiced at large, whether that be through clinical care or research, advocacy, or education. So yeah, thank you for having me back. Today, I'm going to talk about strengthening transitions of care after a hospitalization for patients with substance use disorders. I don't have any conflicts to disclose, but I will say that the work that is mine that I'll discuss today was funded in part from NIDA Q23, the Patient-Centered Outcomes Research Institute, and the Utah Department of Health and Human Services. And by way of just sort of a roadmap for what we'll be covering today, the topic of the talk is about care transitions, specifically focusing in on care transitions from hospital settings after a medical hospitalization to follow-up care for patients with substance use disorders, which are something that, in every health system around the country and really around the world happens every single day, but where there's still a lot of holes in the care that we provide, and an opportunity for us to strengthen support for some of our most vulnerable patients. I will talk a little bit about some of the unique barriers that patients with substance use disorders experience during these care transitions after a hospitalization, some of the interventions that are out there right now to try and make things better, and then some future directions for research and clinical innovation. So I think it's helpful to just sort of define our terms to start and sort of talk about what care transitions are, which, for those of you who practice clinical medicine in any setting, whether it be outpatient clinics or in the hospital, this is something that is just sort of foundational to our practice, right? People that we care for are transitioning in and out of different medical settings during acute illness all the time. And there's a lot of different definitions for sort of what exactly constitutes a care transition. The ones that I like the best are the ones that focus really on the sort of patient point of view, sort of defined as the holistic patient experience of transitioning from one medical setting to another, whether that be from the hospital to home, whether that be from the hospital to a skilled nursing facility or a long-term acute care facility and then home, or sometimes patients are transitioning to sort of the unknown, right? It may be a friend's couch, or they're not sure where they're going after they leave. And in a perfect world, we sort of envision care transitions as being this, newly paved road with arrows clearly demarcating the way. from a care setting to where we'd like them to end up. But in reality, I think we all know that they're quite a bit more complex and messy, probably more akin to this picture, where patients are having to navigate a lot of different barriers to following up for continuity of care, whether those be things like social instability or lack of access to transportation, insurance that may not cover their follow-up visits, or even their discharge medication sometimes, and then persistent symptoms that they may be experiencing from their acute medical illness. And all of these things kind of stand in the way of a clear transition to care. And the other part of this picture that I think is, salient is that folks are oftentimes left to their own devices, truly alone in trying to overcome these barriers and get to follow-up care, which is why, it's a time where people can really fall through the cracks of our healthcare system. For patients with substance use disorders, this is all happening kind of on the background of the ongoing overdose public health crisis. Despite some, small improvements recently, we're still experiencing over 80,000 preventable deaths per year related to overdose. We're now in the third decade and the fourth wave of the overdose public health crisis, now mostly defined by the ubiquity of potent synthetic opioids like fentanyl and its analogs, co-used with stimulants like methamphetamine. Beyond the publicized overdose deaths, we're also experiencing an increase in deaths related to alcohol, which kind of gets short shrift in these conversations, but actually are estimated to directly account for over 185,000 deaths per year, and increasing deaths related to methamphetamine use alone as well. For people who use drugs, they are confronted with an increasingly unpredictable illicit drug supply. A lot of this stuff makes its way into the lay press. But as fast as you can discover the new adulterants adapted from veterinary medicine or who knows where else into the illicit drug supply, there's another one coming down the pike, whether it be medetomidine or xylazine, or now novel compounds that really have no precedent for use in any kind of clinical setting. And despite this really scary situation, less than a quarter of people with substance use disorders access any treatment at present. And in order to make treatment more widely available, I think people who work in the addiction field and federal agencies like SAMHSA really champion this no wrong door approach to treatment, meaning that wherever anyone who uses substances accesses community services, medical care, really anywhere there are in the community, they should be able to access treatment there, right? That's where we want to build those entries into treatment, so that if people have that change moment, they can take advantage of it right there and then and seamlessly link to treatments. And hospitalizations are really, uniquely suited to this, right? The hospitalizations are oftentimes kind of a moment of change and reconsideration if someone's acute illness perhaps has to do with their substance use, kind of a reachable moment, if you will. And also, substance use disorders are just really common amongst hospitalized patients. This is work from UCSF's Leslie Suen and others who demonstrated that fully 1 in 9 people nationally who are in the hospital are estimated to have a substance use disorder, as well as 1 in 10 people in emergency department settings. So it's really kind of an enriched environment with people who would benefit from access to treatments. And UCSF has been really a national leader in building in infrastructure into their hospital and inpatient care teams to help facilitate treatment initiation through the advent of things like addiction consult services and buprenorphine initiation protocols that make it easier for hospital teams to offer treatment to patients. And that has been remarkably effective, truly a game changer, and getting people started on substance use disorder treatment. The problem is that all of that amazing support that people experience in the hospital oftentimes completely evaporates. When they leave, and they really can feel alone in trying to navigate to what sometimes are limited options for follow-up care. And it probably won't come as a surprise to you that post-discharge time period is particularly fraught and dangerous for patients with substance use disorders. Across a few different studies, the 1-year post-discharge mortality for patients with opioid use disorder is estimated to be about 8%. And this is work that we did using a national VA sample showing that the risk of dying within the first 2 weeks of hospital discharge is roughly 3 times higher than the risk of dying between 90 and 365 days after discharge amongst veterans with opioid use disorder, meaning that immediate post-hospital discharge period is the most important time really to intervene, provide extra support in order to potentially save people's lives as they transition to care. Inappropriately, I think a lot of our concern and work towards improving care transitions is focused on improving the patient experience. But I will say that hospital care transitions affect care team members too, right? This is work that we did as part of a QI project at the University of Utah that I'll tell you more about later. At the beginning, we interviewed our hospitalists, so 71 hospitalists at our site, about their experience with care transitions for the patients they care for with substance use disorders in the hospital. Nearly everybody reported that they never or rarely received any kind of post-discharge updates about their patient. And it's sort of even worse, the updates they do get are the patients that get readmitted. So it's really only negative feedback. And discouragingly, only 13% of the folks surveyed believed that their patients with substance use disorders often linked to follow-up care. And 3/4 believed that kind of uncertainty, doing all this work to care for patients with substance use disorders in the hospital, but then never finding out what happened to them, contributed to burnout, which is not surprising. I think, if there is sort of a moral injury associated with, discharging your patients and having a very low sort of belief that their long-term outcomes are going to be good, despite everything that you did for them in the hospital. So what are some of the barriers that folks with substance use disorders face once they leave the hospital when they're trying to link to follow-up care? Well, some of them are not unique to having a substance use disorder. They're just the sort of general barriers that anybody that is leaving the hospital and trying to link to continuity of care would face. That may be new medications and their attendant side effects for whatever their acute illness was. It could be a complex follow-up plan that involves, multiple specialist visits, perhaps at clinics that are not easily accessible without a car. It could be debility from the hospitalization. I mean, we're joined by Ken Kaminsky today, who kind of coined the term hospital-acquired disability. And I think, while that especially applies to older adults, I think really anybody that spent significant time in the hospital is going to have to contend with, having to learn how to provide the basic necessities for themselves again amidst recovering from their acute medical illness. And then for patients that use opioids, and we're not exposed to them in the hospital, they oftentimes will have a reduced opioid tolerance after discharge. And that's the sort of set of circumstances that these patients are walking into the elevated overdose and death risk period that we were just talking about earlier, where they're confronted with barriers that oftentimes are unique to having a substance use disorder, like the return of cravings for whatever that substance was, withdrawal symptoms, discharging right back into the same social environment in which you were using that substance before without a lot of additional support, lack of transportation, unstable or lack of housing, especially for folks who live in rural areas, a lack of local substance use treatment resources, or if maybe there is one substance use treatment program in town, maybe you've had a bad experience there in the past or burned some bridges and experienced stigma. And so truly it feels like there's no options for follow-up care for you. We've done a little bit of work asking patients about their experiences with post-discharge care transitions. This was a qualitative study in which we recruited patients in the hospital that had a substance use disorder, and then 3 weeks after discharge, called them and interviewed them about their experience, and generated a lot of really, rich themes about what happened to them after they left the hospital. Some representative quotes here just highlight some of this, right, where they talk about really feeling alone with nobody reaching out after they've left the hospital. And then that notion that they weren't able to take care of themselves when they got home. They didn't have the right durable medical equipment, or they weren't able to pick up their medications because the copay was too high, or sometimes they just weren't able to get up the stairs to their apartments. And sometimes ending in a moment of desperation where they just had to flag down a bystander, or in this case, law enforcement, and ask to go back to the hospital because they just weren't able to care for themselves after they left. As a part of this study, we also asked patients what an ideal discharge situation would look like for people with substance use disorders. And I'll just read this quote that I really think sums it up well and that inspired the title of this article. To sit down and have a person come to you and say, okay, we're going to send you home. We're really concerned about your well-being and the future that you're walking into once you go through those doors. And we want to give you the best chance to do that. So here's what we've got for you. You're going to get a phone call from the peer support nonprofit. And there's going to be a coach that's lined up for you. We're going to contact them and make sure that's happened. Then a phone call from nursing. Have you been able to shower and cook meals for yourself and stuff like that? That's great. For people that have mental health and substance use, co-occurring situations, they don't just need a handshake or a handoff, they need a hug to encompass and circle them and make sure that they know that they have people that genuinely care. And I think we can all agree that that is an ideal, that we would like for all of our patients that we're discharging out there into the world. We've done some work interviewing and surveying our hospitalists too about this. This is a survey that we did across 15 hospitals in Utah, including rural, frontier, and urban sites about what they perceived as barriers and facilitators to care transitions for people with substance use disorders. I'll highlight that, the vast majority believed that people with substance use disorders have unique post-discharge needs and that added supports they thought would work to improve care and clinical outcomes for this population. And that only 5% believed that their patients were receiving adequate support during transitions of care. And when we asked them, what we thought would make the biggest difference, both in terms of what are the barriers that we need to overcome and what are the facilitators that could help people get better care after hospitalization, we were sort of surprised to find that it wasn't actually like hospital-based resources that they were looking for, right? It wasn't, oh, I wish we had more time to, care for this patient prior to discharge or, more specialty addiction expertise in the hospital. It was actually outpatient resources that they thought would make the biggest difference, whether that be overcoming barriers like a lack of social support or social barriers like a lack of transportation, or adding things like a partnering outpatient clinic or extra outpatient staff to really help their patients connect to care. Again, I think this kind of just speaks to the disconnect that can exist between outpatient and inpatient care environments when we're talking about providing care for patients with substance use disorders. So what's out there in terms of promising interventions now that people are trying to overcome these barriers and improve care? In other words, what's the best approach to supporting patients with substance use disorders during care transitions? And I'll start just by saying that, care transition research extends far beyond the field of, people with substance use disorders. There have been, many interventions tried across many populations that are at increased risk for hospital readmissions. Patients with chronic health conditions like heart failure or chronic obstructive pulmonary disease, patients who are older who, kind of have a high degree of frailty, and a number of different interventions have been tried, ranging from an enhanced post-discharge teaching to pharmacy or nursing-based interventions. And despite all this work, I still think, there's not really one, consensus approach on the best way to support folks as they leave the hospital. Sometimes interventions have been successful at reducing things like readmissions, and sometimes they haven't. And, I still think we're searching for sort of the best approach to help patients in general during care transitions. For people with substance use disorders specifically, this is work that was done by some colleagues up in British Columbia, a systematic review without meta-analysis, just looking at what's out there in terms of published models in the peer-reviewed literature about what people have tried and studied to improve care transitions specifically for people with SUD. This group looked for both ED and hospital-based models, and they identified 10 through their literature review, limited to studies that measured some kind of clinical outcome, like post-discharge care engagement, retention and treatment, et cetera. And there were things that many of you maybe have experienced in your clinical work, like addiction consult services or peer navigation. Sometimes something as simple as just a buprenorphine initiation protocol for clinicians to follow, like an order set or something like that. And they found that, most of these things had a pretty like weak evidence base. They'd been tried in perhaps a single site in a small clinical trials. And even then, it had showed mixed efficacy in terms of what worked best. We read this, myself and my mentors and colleagues with a lot of interest, and we're, interested in digging a little bit deeper and perhaps, synthesizing some of this evidence to something that would be more useful for clinicians. So we ended up contacting this author group and asking if they wanted to partner with us on more of like a narrative review that we could add a little bit of additional data to and better characterize some of these models, which we did. It was published a couple of years ago in JAMA. And so we redid their literature search, expanded the search terms a little bit. We added a gray literature search. And then importantly, we actually contacted 10 national experts around the country who we knew were doing innovative work related to substance use care transitions, and interviewed them about unpublished models or things that they were seeing and trying in their communities to try and improve care, which were very rich because a lot of this stuff just hasn't made its way into the literature yet. We focus specifically on post-hospitalization care transitions and not the emergency departments. And we sort of, again, synthesize some of this to have kind of a implementation focus, like how could health systems and inpatient clinical teams utilize this information? We ended up with 10 models that we sort of characterized as being primarily inpatient-based, meaning that most of the activities happened while the patient was still in the hospital. Transition-based, which are interventions that sort of start at discharge and are aimed to link patients to continuity of care somewhere else, or outpatient-based, meaning like an outpatient clinic or program that sort of catches patients after they leave the hospital and tries to link them to long-term care there. For example, like a bridge clinic, which is like a low barrier outpatient clinic where people can walk in, without appointments and access low barrier follow-up medical and substance use care. We found, through these interviews and literature review that we were able to typically determine what the core staffing looked like for each of these models, what their core activities look like. And then we tried to, discern what the relative level of investment was to implement these, both for inpatient clinical teams and health systems. For example, buprenorphine initiation protocol, it doesn't require much work from a health system perspective to implement, but all the inpatient clinical teams that are going to have to learn the protocol and then use it, that's a pretty big lift for them amongst their other clinical responsibilities. Whereas an addiction consult service requires quite a bit of investment on the health system level or the hospital level, but actually makes life quite a bit easier for the inpatient clinical teams who now have this sort of embedded expertise on the medical service to help them with their patients with substance use disorders. An interesting thing that we found in doing this work was that there's really only 2 models that were designed to span all 3 care domains, the inpatient, care transition, and outpatient domains. And this was this idea of a continuity enhanced addiction consult team, meaning an inpatient team that either had a partnering outpatient clinic or some kind of facet of the team that actually continued to provide care and follow the patient after they left the hospital. And an outpatient in-reach model, which is like an outpatient organization that actually goes into the hospital and meets the patients before discharge, does an intake, develops some rapport, exchanges accurate contact information, and then continues to follow that patient after they leave and guide them to longitudinal treatment, either at their program or perhaps somewhere else, according to the patient preference. And we were really interested in the sort of implementation and what models really were the most promising to do further research in of the ones that we were able to discern through this narrative review. And while our author group did a lot of work to try and measure the relative implementation requirements for each model, we decided that we were going to convene a Delphi panel as well to really look at each one of these models and rate each one according to their anticipated effectiveness and feasibility in terms of ease of implementation. And to do this, we convened 25 interdisciplinary experts, all of whom who had some kind of experience working with substance use disorder-related care transitions. And we asked them, of these 10 models, which did they think were the most promising? And we found that they largely agreed with us. The models that had the best combination of feasibility and presumed effectiveness were the addiction consult models, these bridge clinics, which are these low barrier, kind of walk-in combined medical and substance use disorder outpatient clinics, and then the InReach from outpatient models as well. So, in a field where there's not a lot of peer-reviewed or randomized clinical trial evidence yet, this highlights, at least according to expert consensus, some models that are promising, that are out there, that are worthy of further research. Just to give you a little bit of a more detailed picture of what some of these models look like and what research does exist supporting them, we'll start with the continuity enhanced addiction consult team. This is a study of really like a prototypical addiction consult service from all the way back in 2014 in JAMA Internal Medicine that looked at an inpatient team that provided addiction expertise in help with buprenorphine initiation, buprenorphine being an FDA-approved medication to treat opioid use disorder, while patients were in the hospital. And then they had a partnering outpatient primary care clinic that they work with, and the randomization was either to start buprenorphine and hand them off to this partnering clinic, or it was to start buprenorphine essentially to treat withdrawal symptoms, and then the patients would be left to their own devices once they left the hospital. And I think in hindsight, no surprise that the patients that had that kind of buprenorphine continuation did better in terms of having less substance use at 30 days. But the care linkage rates are just really impressive to report here. 72% linked to outpatient care at a primary care setting, which generally has a pretty high bar for follow-up, right? For patients that have a lot of social instability, you have to show up on time, to a particular building that's brick and mortar. It can be a challenge, and yet almost 3/4 of patients made it there, compared to just 12% in the comparator group, and retention at 6 months. Also 17% versus 3%. So, starting the medication, crucial component to this, but hard to underestimate the importance of having that partnering outpatient clinic to provide the continuity of care as well. This is another example of a continuity enhanced addiction consult service model. This one, it was at a single site in Baltimore where everybody in the trial got to see their inpatient addiction consult service, but half the folks were randomized to meet a master's level social worker that met them in the hospital and then continued to follow them for 3 months after discharge, providing phone outreach and care coordination, and finding that amongst the patients randomized to the intervention arm, they were about 1.5 times more likely to link to addiction treatment within the following year. This is probably the definitive randomized control trial of addiction consult services and continuity of care that doesn't involve that sort of continuity enhancement. This is the CATCH trial that was published in JAMA IM just last year, I believe, maybe 2 years ago, across 6 hospitals in New York City, showing that amongst people that had access to an inpatient addiction consult service, treatment initiation and retention was much better than not having access to that, right? People were 8 times more likely to start buprenorphine and 7 times more likely to remain engaged in treatment at 30 days. But I will say that the treatment engagement was quite low in both groups, and you can sort of tell the difference, right, between the study, despite their differences in design, that had kind of a partnering outpatient care plan or a clinic for patients to follow up in versus ones that, exist in this huge health system in New York City and where patients didn't really have that kind of warm handoff. Most of what we talked about so far is care transitions related to buprenorphine, but methadone, which is, sort of the other very evidence-based treatment for opioid use disorder, in which can be started in the hospital, presents like very unique care transition challenges, right? Because methadone can't be prescribed in outpatient settings for opioid use disorder. It has to be dispensed through federally licensed methadone clinic or opioid treatment programs, which in many areas are few and far between. Like Wyoming has 0, for example. And there are a lot of administrative barriers to care, even in places like San Francisco, where there's many OTPs. And in the era of fentanyl, this has all been kind of compounded by the fact that sort of older methadone titration protocols were generally used to going very slow to mitigate side effects. And so patients were leaving the hospital, facing these administrative barriers to finding a methadone clinic to continue treatment, and also not having their cravings and withdrawal adequately controlled. And shout out to Marlene Martin here at UCSF, amongst others, Scott Steiger, Leslie Suen, et cetera, for really leading the way in teaching other health systems how to do more rapid methadone titration protocols, which is really key to helping with a successful care transition, right? Because if you leave the hospital and your cravings aren't controlled and you're in withdrawal, you're probably not going to wait to that follow-up appointment in 3 days, or get up at 6 in the morning to go try and get an intake appointment at the local methadone clinic. You're probably going to do the easiest thing, which is go to try and find fentanyl, which you could probably do in a matter of hours, and use that instead. So, working to get people to a therapeutic dose of methadone quickly before they leave is something that is really quite new in the addiction treatment world. And, the protocols that are now shared with health systems across the country are largely owed to the innovation that happens right here at UCSF. Colorado, Susan Calcaterra and her colleagues have also really done a lot of work related to methadone care transitions. This is really exciting and leverages some recent changes to federal methadone policy that allow for telehealth-based enrollments into methadone clinics, which was never allowed before a couple of years ago. And Susan and her team in Colorado have now developed these protocols within their addiction consult service, where they will do a methadone initiation for folks in the hospital, and then actually do a telehealth-based intake to a partnering methadone clinic while the patient's admitted, so that when the patient leaves, not only are they on a therapeutic dose of methadone, but they're already established at a local OTP, or opioid treatment program, and can just walk in there, can be assured that they are going to get their dose that they were discharged on from the hospital. And they don't need to show up early to get one of the very few intake appointments that methadone clinics typically offer each day. They can just show up like a regular established patient. And that may sound like common sense to people who haven't done a lot of work with methadone before, but it's truly revolutionary in terms of what's possible in terms of making these transitions of care easier for patients. And now Susan's doing work teaching other health systems how to do this as well. So really some important changes that support care transitions for people starting treatment in the hospital. The last existing model that I'll cover is this outpatient in-reach model. There's not much research about this, but there is at least this one RCT that's representative from Denmark that was done by an alcohol treatment program that on a randomized set of days of the week would go in and meet patients admitted with alcohol-related concerns, and they would meet them and then attempt to recruit them to follow up in their treatment program after discharge, providing ongoing outreach to people that were randomized to that intervention, and finding that while follow-up was low in both groups, it did make a difference to have the intervention. It was a positive study. So, that is sort of what people are already doing out there in terms of improving care in this area. So now we'll sort of close on talking about some future directions for research and clinical innovation that I think are important to explore as we move forward in trying to improve care for this population. And I'll just preface this by saying that, if we're really trying to make a dent in care access, right, if we really believe in this no wrong door for treatment model, we really need to invest in scalable models for helping people follow up after a hospitalization. And I think that's going to require that primary care get involved, and that is particularly important for a number of reasons. Probably first and foremost, that primary care really has the geographic reach and infrastructure to actually, provide care to, 1 in 9 hospitalized patients across the country that would benefit from linkage to ongoing care. Truly, while the specialty addiction kind of outpatient treatment programs are important and add important expertise, they're not really a scalable solution to address this care transition problem alone. And I'll just add that there's a lot of reasons that primary care is an optimal place for many people with substance use disorders to follow up for continuity of care. One is that actually primary care physicians are really good at prescribing or providing addiction treatment. There have been a couple of studies demonstrating this. This is one of them, essentially, that shows across a number of quality metrics related to substance use disorder care primary care settings did as good as specialty behavioral health treatment settings and things like treatment retention and screening for HIV and hepatitis C. And so, primary care clinics are actually quite good at providing addiction care to patients. Patients also just really appreciate it. This is work that we did at the University of Utah, just doing some qualitative research around the patient experience receiving addiction treatment in primary care. And I really like these quotes. One says, "I feel like they all genuinely care about what's going on, even outside the medical part, just in general. All his nurses have been super cool to me. That's why I've never been with a provider this long. I feel like I can go to him with anything, and he's not going to judge me or anything like that." And the next quote says, "I don't have to go to different places or see different people. It's all with one person. So I can get comfortable with that person and take care of the needs that I need to be taken care of," which, that's just kind of par for the course for what people like about primary care in general, right? That sort of continuity with a trusted team, the ability to have all of your healthcare managed under one roof and not have to single out the addiction piece, which can be stigmatizing for a lot of people. In the sort of chronic disease models and team-based care that are integrated to a lot of primary care already. So, a lot of advantages to doing this. The problem is that primary care physicians oftentimes don't prescribe buprenorphine, right? And many studies say as few as 10% of PCPs provide addiction care with buprenorphine. So how do we inspire and support the primary care environment to provide, to do better, right? To provide enhanced addiction care to more patients? Well, one model, and really the focus of my clinical work, is this idea of kind of integrated addiction medicine and primary care, something that I definitely learned here during my time at RFPC at San Francisco General Hospital. And this model essentially means like integrating addiction expertise just into regular, sort of typical primary care settings. Our clinic in Utah is called Spark. We sit like squarely in the middle of our sort of giant primary care patient-centered medical home. And it started as just myself and a care manager. And even then, we had a large impact on transitions of care from our health system, from acute care settings to primary care follow-up. So this is just data from our first 15 months. Now, kind of feels like ancient history from emergency department-based buprenorphine initiation and aftercare program, where we, very quickly nearly doubled, or I would say more than doubled our health system's capacity to take patients receiving substance use disorder treatment, had about 50% greater care linkage and more than double the retention and care over 6 months, even with a pretty lean team and no funding at the time. So these integrated models can really make a difference in sort of increasing capacity and then showing other PCPs in the health system, like sort of what's possible and just, having addiction care feel like it's more of a normal part of the primary care clinic experience. So we love the work that we do in Spark. And it feels like oftentimes here we are in this sort of outpatient setting. And for our referral pathways, which include like the hospital and our mental health receiving center and the emergency department, we're trying to kind of meet the patients, in this very, tenuous period in which they're trying to navigate all these care barriers to care to follow up. But what if we could actually meet the patients earlier and actually turn our clinic into more of one of these like in-reach models where we can meet the folks in the hospital and then really walk that road with them. And that's the main sort of subject of my K23. It's developing and studying the feasibility of one of these in-reach interventions, which we're calling the Interdisciplinary Addiction Care Transition Team, or INTACT. And it's designed so that different health systems can, make these out of whatever sort of clinician resources are available and interested in doing this. For the pilot trial, it's going to be a primary care physician, a peer support specialist, and a nurse care manager. Is the case with many pilot studies, it's got mostly a feasibility kind of implementation science focus, although we are measuring some effectiveness things like care linkage and retention. And shout out to Dr. Rita Redberg, who was instrumental in helping me successfully apply for this K award. In the future, I feel like there's a lot of opportunities to do comparative effectiveness research as sort of a next step for this, sort of develop the model and kind of work out the kinks through this pilot trial, but then ask some really important questions like, do you need a team to do this? Is there any advantages to doing this versus just having a single clinician like a social worker follow the patients after discharge? What are the relative differences in investment and cost to health systems, to acceptability, to rates of like workload and burnout for clinicians who do this work, and then also to the patient experience and clinical outcomes as well. Another piece of this work is just figuring out how to engage PCPs into doing addiction-related care. This is work done by my colleague Taylor Kelly at Utah using a national VA sample, showing that the things that were the biggest incentives for people in primary care to provide buprenorphine for opioid use disorder were feeling like it wasn't going to add a lot to their already like overstressed workload, right? And so that's what we think that these integrated addiction medicine primary care models can be really helpful, and just sort of clinically and anecdotally, we've seen it happen where, just having an expert that sits down the hall from you and is willing to help you with your patients really like makes you feel more comfortable and excited about doing the work of taking on that addiction treatment, because that there's somebody that you can ask for advice if you need it, or that will actually see your patient and provide at least interim care and support. And not just, from a physician perspective, but from a care management perspective and a peer support perspective. And that I think makes all the difference to busy PCPs, knowing that they've got that kind of backup if they're going to take on this kind of new area of care. I was telling you a little bit ago about the sort of moral injury that can happen to hospitalists when they're discharging their patients and not really ever figuring out what happened to them after they left the hospital, and how that can lead to sort of this sense of futility that all this work they're doing to start buprenorphine isn't really going to ever translate into meaningful long-term gains. And so one thing that we did this past year was start a feedback system that we called Courier, where from our outpatient primary care addiction medicine program, for all of the folks that we got that were transfers from the hospital, we would actually look back and find out who the people on their hospital care teams were. And we would send them, if they enrolled into the intervention, these periodic updates at 3 weeks and 3 months about like what happened to their patient after they left. And we, identified the hospital teams just through EHR notes. And then we made it really easy. There was no response required. We just embedded it into a secure email. And it was just a bulleted narrative summary that just said, hey, remember that patient you cared for 3 weeks ago? Well, they made it to their follow-up and they finished that course of antibiotics that you prescribed, and they're still taking buprenorphine. And then we did it again at 3 months, saying, remember that patient that you cared for 3 months ago? Well, they're still attending appointments with us, and they, got housing, and they, just celebrated 3 months of no substance use, or whatever those milestones were that the patient had accomplished in the interim. And we personalized these just so that we emphasize the role of the hospital care teams in contributing to these health-related gains, right? Like, you cared for this person in their time of acute need, and that work that you did really made a difference in terms of the health gains that the patient later experienced. We just finished with this work, and spoiler alert, it did lower burnout rates amongst people that participated as opposed to a non-randomized control cohort that we had. But the mixed methods evaluation was my favorite part. And this is just a quote from one of our hospitalists that we interviewed who participated in the project. It says, you're actually seeing real life folks that you've taken care of who are now continuing to succeed, continuing to progress, continuing to try and shoot for that goal that they had of sobriety. And it gives you hope. Like, hey, this is working. I continue to root for them and pull for them as I'm hearing some of these status updates about how they're wanting to continue to stay in this path. So it's great to hear, and it's great to see. It gives you hope for that next person who might be receptive to that and wants to change. Like, hey, I've seen it work in other folks, and hopefully you're the next person who goes on this path too. But I really love that quote just because it sort of speaks to the changing mindset that can happen if you actually believe that the treatment you're providing is going to potentially have like a lasting effect after the person leaves the hospital. And then, just a couple more here. I think that they're doing this work, which is, I hope I've impressed upon you all, is pretty nascent in terms of, a body of research evaluating these different models. I think there's really an opportunity to define what kind of outcomes we're measuring. I mean, there's the sort of, standby care transition outcomes like hospital readmissions and, care linkage within 14 days and retention at 3 months, which, oftentimes are kind of HEDIS quality measures as well. But we're not really sure if those are the outcomes that actually matter to patients or not. And I think, where there's fields that are early in doing research, there's really an opportunity to convene multiple partners to really generate like what outcomes should we be assessing in when we do this research. And so we got a small engagement award from PCORI to do that, bringing together people with lived substance use experience, peer navigators, outpatient clinicians, inpatient clinicians, nurses, social workers, physicians, this really diverse group of folks to try and develop a patient-centered core outcome set to inform future care transition research, as well as a partner-informed prioritized research agenda. And it's been really a joy to do this work because just, hearing everybody, getting everyone in the same room and through some structured, focus groups, conversations, a community advisory board, we've really been able to bring folks that never get to talk to each other about these experiences together and sort of compare notes and talk about the things that they feel like are working and the things that they feel like, aren't working or that they're not sure about. And so, we anticipate wrapping this up in the next year, and we're excited to share the results. And then finally, I think, there's really an opportunity to involve more than just primary care in this work. I really am into collaborative care models, and I think care transitions are really, especially sort of relevant to collaboration between primary care, addiction medicine, and medical specialties, because a lot of the things that people get hospitalized for are things that they're going to need specialty care for after they leave. And I think many of you have likely had the experience where, by the time you see the patient in clinic, they've already missed 2 specialty appointments, and you didn't really have a chance to intervene on that before you really even saw them. And so, developing collaborative models between, for example, addiction medicine and infectious disease to work on sort of antibiotic strategies and follow-up care for people with injection drug use-related infections. One of our strongest collaborations which is with cardiology for people with stimulant-associated heart failure and pulmonary hypertension, collaborative care models with hepatology, which former UCSF fellow Rebecca Kim, who's now at Utah, is like one of our primary partners in doing that work, and more. So, having these collaborative care programs already in place and nurtured improve not only, the care experience that patients are having, once they're established in terms of getting extra support to engage with specialty care, but also can have an impact on care linkage. If you already know that hepatologist that this patient's leaving the hospital scheduled to see, then it makes it much easier to sort of reach out to them and make a collaborative care plan to try and facilitate linkage to both specialty care and addiction medicine in the future. So in summary, the urgency of the overdose public health crisis requires building treatment into general medical settings, using this no wrong door approach. There are established models for assessing and treating substance use disorder care in acute settings, but care transitions are oftentimes a weak link. People with substance use disorders have unique challenges and needs when it comes to supporting care transitions, and partnered research approaches are key to ensuring relevance and effectiveness of novel interventions. Interventions that span care settings and leverage interdisciplinary care show the most promise, but may also be the most challenging to implement in primary care is integral to scaling and implementing these models, but appropriate support is needed. That's everything I have. Thank you.
Got that. Why don't you go to the mic, Mike? Thank you. That was terrific and inspiring. Talk about the economic case to do this in the outpatient setting. You probably have to sell this to somebody, maybe in the health system, and I imagine the case is easier to make for an inpatient team than an outpatient resource. So how do you make that case? Obviously, the moral case is pretty easy, but the business case may be harder.
Yeah, I mean, I do think that it helps to consider this as part of a kind of a whole health system-based intervention, because I think when you think about things like preventing hospital readmissions, then the cost savings are marked. But I think that the way I think about it too, and the way that I talk to our health systems leaders about, primary care being more invested in this is that, these are folks that are ostensibly able to establish care longitudinally in our health system. The beauty of primary care is that if we can capture these folks as they're transitioning out of, acute care settings like the emergency room and hospital, then these are folks that are going to fill up our primary care panels, fill up our clinics, and ultimately be long-term patients. And for us, we have really great follow-up and retention rates. I'll bet on par with, just regular hospital care transitions that have nothing, and don't have substance use disorders. And so, I think we have demonstrated to our health leadership that the economic case is really about, getting more people for long-term care and keeping them out of acute care settings at the same time.
Right. And then in terms of you made the case that the right model here is a primary care model and kind of everybody can or should be able to do this. And then, but also said that your model had you and someone helping you embedded in primary care, and you're obviously a specialist in this. What's the right balance of those two things? And to the degree that it requires specialization, is that knowledge of the drugs? Is that knowledge of the system? Is that empathy and sort of the fact that you like taking care of this group of patients, whereas probably not everybody feels that way? So how does that all balance out?
Yeah, I think that is an excellent question. And I do think that, primary care needs support and inspiration to do this work, because, I think working in a primary care setting, you're always being asked to do one more thing. And I think oftentimes this feels like a big lift. And in talking to our primary care providers in our health system and just, colleagues nationally, I think people especially have trepidation around taking on substance use disorder care, because they believe that, there's going to be a lot of sort of psychosocial chaos and no-shows to their panel. And it's just going to be kind of opening this Pandora's box. And so I think...
Are they wrong?
I think they are. I think, but I do think that it requires, that integrated support to really improve outcomes. Like I was showing on the slide with our clinic, doing outreach, having some care manager support, and having some expertise within your health system really improves, retention and care linkage. And that has been the case for our PCPs too. Like just anecdotally, for example, people that we hand our patients off to once they're stabilized and will take over their primary care and addiction treatments. Well, if they're having trouble, if they've got medication questions, if their patient's not showing up for visits, will reach out to us, and we'll oftentimes provide that extra layer of support, whether that be care management, peer support services, medication titration, interpreting test results, Hep C treatment, whatever it is, we're there. But I would say that probably like 85% of the care, the PCPs take care of no problem. And it's just really knowing that they have that extra support that they can take advantage of if they need it. That makes all the difference,
Right. Let me open it up to questions or comments people have.
Hi, Dr. Mosi Williams, social worker. I want to thank you for your work. And I wanted to ask about the courier project you've done, if that was available to other services, because there's nothing worse than opening a chart, wondering what happened to a client or patient, and you see that they're deceased, or you see that leaf and, letting you know that they're gone, and not having any kind of follow-up.
And I have another question about that. Do people get only good news that the patients get followed up, or they also hear that we never saw this person again?
No, those are both excellent questions. And I will say that we only give good news. So if the patients haven't followed up, we don't send, the negative updates.
Did you think about that? Because you wonder, are you giving people an appropriately calibrated sort of reality test of what happened?
We did. And in fact, in our original model, we had included like updates regardless. But, we felt that the importance of sharing some wins. I think, in talking to some of our hospitalists, their baseline opinion of what was happening in terms of care linkage with their patients after discharge was already starting at a lower than what is reality. We felt that there was many more patients that actually were having positive health outcomes than what was the perception. So for at least this iteration, we really focused on just sharing positive updates with folks. And then in terms of sharing the model, yeah, I mean, there's certainly nothing proprietary about it. And I'm happy to teach you about what we did. We are going to publish our little mixed methods paper about it and are trying to grow the work at our institution. But if you reach out to me via email, I will share anything and everything that I know about it with anyone who's interested in doing it.
Yeah.
I was curious that access to behavioral health or mental health services didn't come up more highly, either from what providers felt they needed or from what patients felt they needed. And I wondered if that was sort of my bias of like a stigma of the comorbid substance use and mental health needs that are pervasive across the population, whether you're a substance user or not, or what you think the role of that in this sort of embedded primary care addiction medicine model would be.
That's such a fantastic question. And yeah, behavioral health in our health system is hard to come by. There's, it's a very limited resource. I think that, kind of like with addiction treatment, in primary care, they're pretty accustomed to and skilled at taking care of, sort of 85% of the behavioral health concerns that the patients are going to come with in terms of, depression and PTSD and, the sort of modern patient-centered medical home model oftentimes includes some degree of embedded behavioral health that you can take advantage of. There are patients that are also going to benefit from seeing a psychiatrist for more advanced medication titration. And in those cases, yeah, I think they play an integral role. But I think, the perception is that, we can't do this work without all this sort of pretty intensive backup. And in reality, that backup is really required for a pretty small subset of patients. So it's important to have it, but it's not something that I think is going to need to be scaled to the same degree that, for example, primary care-based treatment would be.
Awesome. A couple great questions online. One is related to what other countries are doing for transitions of care among this patient population, and if they're doing a better job than we are.
There's not a lot of research from, for example, comparator countries in Europe about specific models. I shared that outpatient in-reach model that was from Denmark and some of the work that has been done in Canada as well. I think the sort of outpatient addiction treatment landscape looks a lot different in some other countries. For example, we're really the only country that keeps, methadone treatment under such tight regulation. In countries throughout Western Europe and Canada, people can go get that prescribed at an outpatient clinic. So it's a much lower bar to accessing that particular form of addiction treatments. But I still think that folks are really struggling with a lot of the same issues in other countries that we are. And yeah.
Out here, I think there was one more. So someone's hand up before. Dr. Kavinsky.
Mike, you gave us so many pearls, so it's hard to pick one, but I will. So I was really, I was moved by the quote you had about how to talk to patients in the hospital and the quote about needing a hug instead of a handshake. So I'm curious, just from your vast experience, do you have any thoughts for those of us about what we might do that makes things worse, that makes patients feel that they're getting a handshake and not a hug? And I'm curious if there's what do you do to make them feel hugged besides the hug? Are there words you use? Is there an approach you take? Is there anything specific you say to make people feel that we care about them?
Do you need a hug, Ken? There we go. All right. Go ahead, Mike.
Yeah, that is a fantastic question. And I think, care transitions are such a time of anxiety for a lot of people, period. And I just think taking the time to walk through the steps and the next steps and contingency planning, which I think is a huge thing. Okay, if you're not able to make this follow-up visit, here's a number you can call, or here's a clinic that you can go to where you're not going to need an appointment and they can help you get reconnected to care. And just really sitting down by the bedside and going through that with folks can really help. One thing that we learned in that qualitative study was that people really liked it when different members of their care team would come by too. Like if a physical therapist would come by and they had osteomyelitis or a bad skin and soft tissue infection, and the physical therapist stopped by and told them about some exercises and made sure that they felt like they were okay going home. And if the care manager, checked in to see if they had a ride home, and we're going to be able to had a place to stay and knew about shelter beds if they didn't, etc. Made a big difference, as opposed to just what I think a lot of people experienced, which is, the medical team all changed. There was a new team that came in. They thought they were going to stay for 3 more days, but the team says, "We think you're ready to go. Have your bags packed, 3 hours," and then that's it. And I think they're not detracting from the medical teams at all. That sometimes is the reality of hospital-based care and the competing pressures that we all face. But I think that stuff is what makes people in particularly feel scared and kind of by themselves in those situations. So,
great, Mike. Thank you, and we're proud of what you're doing. It's terrific, and this is really inspiring. Thanks so much.
Thank you, everyone.